So I'm Bob Wood. I'm a plastic surgeon, which has murky connotations. You know, there's facial plastic surgeons, cosmetic surgeons, aesthetic surgeons, but I'm a board-certified general surgeon, board-certified in plastic surgery, and then I did a Craniofacial Fellowship and Craniofacial Surgery, which we're going to talk about a little bit, and Cleft. And what I was going to talk about today is just an update on what I perceive as new last decade sort of thing in cleft lip palate, craniofacial, and some of the common things that we do that come in a pediatrician's office. This is geared towards practicing pediatricians, basically, which is, I assume, a lot of what we have here. And then some will be of interest to other family practice docs, dentists, and so forth. So moving on, start with cleft lip and palate. And, you know, cleft lip and palate is about 1 in 1,000 live births in the Caucasian population, a little more common in Asian races, Native Americans. And so it's relatively common when you add in all the procedures these kids get over the years. We'll see, you know, a new cleft baby a week, maybe a little more. And historically, that's been a third or a half of what's involved in North and South Dakota, Minnesota, and western Wisconsin. The one thing I'll say about clefts that I think is important to understanding it, because from a pediatrician's standpoint, I think a lot of this you're just going to refer, and you want to know what's new and have an understanding of it, but it is a referral. But I think you understand a lot of what's going on with clefts if you understand the concept that a cleft is considered to be a failure of mesodermal migration. So what I mean by that is the embryonic face is a cell bilayer at about 7 weeks of age, and mesoderm is generated between that bilayer and reinforces it. It's felt that if there's a failure in that becomes unstable and you get clefts, is one of the theories of clefting, which is nice because it explains the bizarre clefts you see, craniofacial clefts, the huge variety of clefts, but most importantly, I think, as you'll see here, in the unilateral clefts, they look great. You know, I mean, we meaning, you know, master cleft surgeons make them all look great. In bilaterals, no one does. And the reason is there's not enough stuff there. So my specialty has spent 100 years saying, well, I'm going to cut my triangle here, but you cut yours there. I think my triangle's better. It's not enough stuff. So you can't make a lip and a nose, this thing, columella filtrum, in the real severe clefts. And then I'll show you some of the stuff we're doing to try to mitigate that. If you are a surgeon, you can't help tell people how to do surgery, and no one here cares how do you do the surgery, but all cleft lip in unilateral clefts is now a rotation advancement repair. There are about 15 plastic surgeons in the country that are fellows of the American Academy of Pediatrics, and they had all of us in a room about 7 years ago or so, and they raised hands, what kind of repair do you do? Everyone does this. And this is what I'm going to show you. And the reason is this is the one repair where the scar mimics this thing, this little bump, the filtral column. All the other repairs, they can look good, but they don't really pop at you as these are going to, I think. And that's why this repair gives you a vertical scar in the lip. So here's a kid with an incomplete unilateral cleft lip. And there is 3 months after repair where the scar is still pink. Now, 3 months is when they look about their worst. Still pink, a little contracted, but pretty good looking lip. Here's another kid, complete unilateral cleft, the primary and secondary palate. So this is the typical thing you see, probably the most common cleft that you see. Here she is after repair. And so this is one procedure at 3 months of age. The standard in the United States with unilateral cleft lip repair is that by the time they're going to school, kindergarten, 5 years of age, 6 years of age, the majority of kids are undetectable by their peers as having had a cleft at a conversational distance. And so I think she clearly is going to pass. And I think a lot of them we do is going to pass. If you can't do that, you shouldn't be doing clefts. Because that's what people are doing around the country and have been now for 10, 15 years. So file that one away. So as a practicing pediatrician, it's pretty simple. Your cleft lip kid should look good. You have to be a craniofacial surgeon to figure out they should look good to you. This looks good to you. You know, everyone has an emotional response to these kind of pictures. If they don't, something's wrong. You should get another opinion because cleft kids should look good. You know, we tried to have support groups, and there are no support groups for cleft patients anymore because they don't want to be in the hospital in the basement talking about cleft lip and palate eating pizza. They're out being the quarterback and being the cheerleader and being the swim champion, whatever. So, you know, just file that away. Cleft lip kids should look good. That's about the biggest pearl I can give you there. Another incomplete unilateral. I like this one because can I convince you that the flash is bouncing off here, the scar, mimicking that filtral column. And that's the key. If you can hide that scar as a filtral column, you'll probably get somewhere. Obviously, we work on the nose. We do some other things. All of that does not apply, as I said earlier, to bilateral clefts and the more severe clefts. So there just isn't enough stuff. And in no one's hands do these kids routinely pass. So here, this is actually a hospital administrator's kid, complete bilateral cleft of the primary secondary palate. Here he is after repair. And, you know, I am a surgeon. I can't not be, you know, sort of full of myself. And I think that's a world-class repair. But you look at that kid and something happened, right? The lip looks a little smeared. It's clear that that child had surgery on the lip, or, you know, people ask, what did you bump your lip? Something happened there. And the reason is you just can't make that sort of lip form and nose form out of what is there. This is a very severe unilateral cleft. About a third of this kid is maxilla is gone. Here she is after repair, and this isn't a good repair, but my point is he's a black kid, makes bad scars. But even in this kid, you know, look at where that lip is. We'll revise the scar, work on the nose. By kindergarten, she too will likely pass, with most of her peers as not having had a cleft. An unusual kind of severe cleft, the central part we call the prolabium is very vestigial here. That's what we make the central lip out of. Here he is afterwards. You know, looks okay. Something happened. So what are we doing to get around that? Well, like so much of the stuff in cleft, everything was actually invented 50 or 100 years ago. And it's a fascinating thing. I'm not going to bog you down with this, but I have an IRB to review very early cleft repair. So 1895 till about 1920 is what I'm looking at in Minnesota now. And it's fascinating what they were doing back then. They had very modern thought and technique. They just didn't have any suction, and they didn't have any anesthesia, et cetera. But all the stuff we're doing now, you can find generally. And I think one of the hot tickets is pre-surgical orthopedics. And there's a guy named Barry Grayson at NYU who has been a big champion of this, as the dental people will tell you. He's an orthodontist for a couple of decades now. Cheryl Sermon, who was at University of Texas Southwestern, arguably was the other one. And Cheryl's here in Minnesota with us. And as a lot of the people here know, the dentist probably better than me, this is, in this form, a passive appliance that's made to the kid's cleft. It's like a little mouth guard. And that is serially modified by the orthodontist, birth to 3 months of age when we fix the lip. For us, there's a little extension that goes up and catches the nose. From here to here is non-surgical now. And the cleft is serially modified. When you do that, you are stretching tissue. It's really tissue expansion. If you look at stretched tissue, you're not just stretching it. The mitotic rate goes up. You're increasing. You're creating new tissue. So this is a form of tissue expansion. And if this is a bilateral cleft, pretty routine bilateral cleft, from here to here is non-surgical. See this right there and right there? That's a huge deal to us as surgeons because we can't create, that's called the columella, we can't create that surgically very well. People talk about little fork flaps. It looks like a massive scar. And if anyone has 16-year-old kids with bilateral clefts in your practice, look right here. It's just a massive scar. So that's a huge deal. That's all done non-surgically. And pre-surgical orthopedics, I think, remains one of the big advances, and it just gets more and more refined. The problem is it's very, very difficult. So Tiffany in the back here spent time with Dr. Sermon last week. Do you think you could do it, Tiff, if you went out and practice next week? What? I'm sorry? Yeah, but that's Tiffany. She can do anything. It's hard to do. Most can't. You know, I mean, I've been with a lot of orthodontists. It's very difficult to do. It's very labor intensive. And then there's the issue of getting paid for it, which is a whole other thing. But pre-surgical orthopedics. So What does this mean to you guys? We like to see them in the first week of life, which I think is pretty standard, probably. But I personally have privileges everywhere, including here. But no matter who you use, if they're doing this, they're going to want to see them in the first week of life, because that's when we start this, like day 1, day 2. So here's another bilateral cleft, unusual cleft, incomplete bilateral. Cleft palate. So what's new in cleft palate? Not a lot, and most of the repairs basically revolve around taking this muscle here. This is a schematic of a cleft palate, right? Hard palate, soft palate. This muscle, the levator veli palatini, and putting that together. After that, there isn't a lot new. There was a guy who devised a Z-plasty. That was probably the one original thought in the last half century, but for the most part, most people are making a big deal of putting that together. It's called an intravelar veloplasty. Interestingly, the one prospective randomized study that looked at it showed it made no difference. That was done in St. Louis, and the guy said, I probably didn't know how to do it. So we all think it matters and is the key to good speech. There's 2 little arteries that come out right here and here. The greater palatine supplies the whole palate. So we lift up that tissue on a vascular leash, move it to the midline without tension, but the big thing is you make a big deal out of fixing the muscle. That takes about 30 minutes fixing a palate. Complication rate approaches 0 now. I mean, I think in my 20-year career, I've taken 1 kid back for bleeding. Fistulate very low. It's really a pretty safe stuff. Not to be cavalier with, but it is very safe stuff. Surgeons don't like to talk about cleft palates because you can't show cool pictures. There are all these bloody little dark holes. So here's the palate. Here's it's fixed, and you just see a midline row of stitches. All the work is done underneath. With a cleft palate, the initial problem is feeding. Another reason to see them at early on, first week of life. We have 2 feeding and lactation specialists. You guys probably have 10 here. I don't know. But we're on them right away, as I'm sure you are, if the kid's born in this hospital. And I don't see feeding as a problem anymore. I mean, our kids have, the old literature would say maybe 10% less weight gain. We don't see that. If there is a failure to thrive, it's a slippery slope. If you burn too many weeks, blame it on the cleft. There's usually a cardiorespiratory component somewhere to failure to thrive in a cleft kid. So here's what I like to do. Pre-surgical orthopedics, 1 to 2 weeks. We then do the lip repair at 3 months of age. That's pretty standard in the United States. Neonatal repair rears its ugly head every once in a while, but generally goes away. We can talk about that if anyone has any interest. Palate repair for me is 9 months of age. Most people in the United States are probably 9 to 18 months. We vary it depending on their speech and language development. The bottom line is surgery hurts growth. And yet you have to close the palate probably by 18 months of age or they start to get bad speech. So if I have a Downs kid, I might delay it a little bit. And then after that, cleft nasal. Now all those kids you saw, I worked on their nose obviously at the time of lip repair. We then do a formal nasal repair sometime after kindergarten. This gets later and later for me. And the guys at UT Southwestern say, I'm not going to do it till you're 18, which I don't agree with. But that is a social decision when to do the nose. And then an alveolar bone graft, if they need it, which is putting bone in the gum about 7 to 11 years of age. Speech is a big thing for pediatricians, and because a lot of this falls to you, unfortunately. And like a lip, if you have a cleft kid in your practice, they should have good, intelligible speech at 4 years of age, meaning it's age-appropriate speech, but you understand pretty much 100% of what they're saying. If you don't, red flags go up, okay? And speech problems are okay at 3 to 4. At 6, it's quite late. And the results that I'm going to show you from surgery go down the tubes. So again, the pearl here is, like lips, if it doesn't look good, it's not good. If their speech doesn't sound good, red flags should go up. Get another opinion, call your speech person, see what's going on. Because speech should sound good early on. And what happens is if the palate doesn't work, which is about 20% of the kids, they can't make pressure. So puppy and ball doesn't work, and they can't make those plosive sounds, B, P, things like that, so they drop them. Or they substitute something else, like dog becomes og. They're smart kids. They're going to try to say it somehow. Or substitute some other sound that they can make, like a G sound. Gah, that's a glottal sound. It's made back here farther. Problem is that's hard to unlearn. I just had a kid came in yesterday that was 18 with VPI. Pretty astounding. And surgeons are biased about their work always, and it falls to primary care docs, pediatricians, a lot of times, to catch stuff like that. Historically, it's about 20% of kids. If someone knows what they're doing, no matter what kind of cleft repair, if they're telling the truth, about 20% are going to need surgery just for speech. Seems to hold true. We think we're doing a better job. I can't prove it to you because you have to have several hundred kids who are 18 or probably 16, and by that time you're in the coronary care unit here. So it's all very retrospective, but we think we're doing better. But that's the number, 20%. So what do? It's an auditory finding. We get a speech sample. Any speechies in the room here? Speech people? All right, well, I can lie. Excellent. So we get a speech sample. It's an auditory finding. And if that is bad, and we have evidence of VPI just on the basis of their speech sample, then it's nasendoscopy. And we look in there a little scope. That's at about 3 to 4 years of age. It's a 3 to 4 millimeter scope. They're not sedated, and you can see the palate work. Palate's touching, some closure, another trial speech therapy. Sometimes you're surprised, as I was yesterday with this older kid, palate's not even close. You know that child needs surgery. So we try to quantitate it a little bit. There's something called nasometry, which is a computerized measurement of nasal airflow, and that gives you a number you can follow. We get that too. The bottom line, though, again, big message is you want to be wrapping this up at 3 to 4 years of age. 6 is old. So that's cleft and palate. Again, for most pediatricians, it's a referral. You got to decide who you're going to refer to. And then you are monitoring some of these kids as they grow older. You are seeing them. They're 12, 16. And so we gave you some messages there about, what to look for as they get older. They should look good. They should sound good. Torticollis and plagiocephaly. So if you're a pediatrician, you're going to see that tomorrow. So that's every day. And so let me give you an approach to torticollis and plagiocephaly, which you're going to see every day in your clinic. So torticollis, tort means twist, collis means neck. It really doesn't mean much if you say torticollis. Some abnormal neck positioning. It's very common. No one knows how common it is. I think it's probably more common than 1%. Contributing factors are increased multiple births, advanced maternal age. Probably we're just diagnosing it more. When I was raised in the 60s and 70s, you'd have to have a lot of torticollis before someone found it on the west side of St. Paul, where I grew up. And now we're more in tune to it. Kids who have torticollis frequently have plagiocephaly. We're going to talk about that. In the converse, is it converse? I think so. Kids who have plagiocephaly also have torticollis, so look for both. The torticollis we see now is not what you see in Nelson's Pediatric, and I'm going to show you some examples where a kid comes in like this. Sternocleidomastoid is a fibrous band. The most common torticollis we see is a kid comes in, they're 4 months of age, so it's a 4-month well baby check. They have pretty normal head posture, but they have a flat head. Take that child through range of motion. So you snap your fingers, and they should turn 90 degrees at about 4 months of age. If this is 0, 90 degrees with the shoulder on both sides. And what you'll see in 50, 60% of kids with plagiocephaly is they won't. They'll go 90 degrees to one side, out here 50, 60, 70 degrees to the other, and then you'll see they're cutting it in range because they start doing this, they start extending. That's torticollis. You have to look for it. You won't just see it, but it's torticollis and it needs to be treated. So that's the other pearl here today. Look for torticollis in your kids, because it is the contributing factor to a lot of the plagiocephaly you're seeing. Then we treat it with physical therapy, and I'm going to show you our series of this, but physical therapy cures about 95%. That's in the literature. We have a very large series I'm going to show you, and that's been our experience too. So we're not getting x-rays, we're not doing anything invasive, heaven knows. Then if there's failure to progress, and by this time you probably want to refer them, I don't know, I don't see pediatricians in my practice who are sorting this out. We then are getting an ophthalmologic examination to rule out an ocular component of the torticollis, cervical spine films at that point to rule out segmentation anomalies. Then we consider release of the sternocleidomastoid, this muscle, even if it's not frankly contracted. It's not a great operation, but it has basically a zero complication rate, universally helps, and it's the best we got. Botox, as far as I know, I don't know anyone who does Botox anymore. It's a neuromuscular toxin you can inject into the neck. I don't see it done. Cervical collars I don't object to. There's something called a TOT collar, TOT is probably the most common one used. There isn't a lot of data behind it, don't object. I think it's fair to say if you look at the literature, what you're going to see most common in refractory torticollis is release of the sternocleidomastoid. So here's a kid with muscular torticollis, and here he is at surgery, and that's the sternocleidomastoid, glistening, scar-like. Best theory I've ever heard of, here's another kid with it under anesthesia, she's got this big head tilt. Best theory I've heard about that is it may be a compartment syndrome, meaning these kids are in fetal constraint, pressure goes up somehow within the fascia of the sternocleidomastoid and impedes blood flow, is a theory that has made a lot of sense to me over the years. So, plagiocephaly goes hand in hand with torticollis. Again, if you're in a clinic, you're going to see it tomorrow. It's extraordinarily common. Plagiocephaly, if you just say plagiocephaly, it means an obliquity of the head. It doesn't tell you what caused it. You can get plagiocephaly because you have craniosynostosis. You can get plagiocephaly because you're laying on the back of your head a lot, or you got torticollis. Again, incredibly common. We don't know how common, but I personally have seen over 9,000 kids with it since 1999, as I'll show you. The key to plagiocephaly is to identify it early and treat it early if you're going to treat it. Early is like 4 or 6 months of age, which is a problem too. This is one of the things that busy pediatricians frequently ask me about, because a lot of kids have some plagiocephaly or cone head or whatever you want to call it, abnormal deformational plagiocephaly or deformational head shapes at that age. But you want to start sorting it out then. 85% of calvareal growth is done by 3 years of age. So even if you have a kid that's 2 and they have a lot of flatness, they're probably going to carry it throughout their life. Calvareal growth now, not facial growth. We use selectively cranial orthoses. I'm going to show you that. That used to be controversial. It isn't now. In fact, I think Fairview now has their own program. So the first thing, when you see a kid with deformational plagiocephaly, you're looking at the top of the head. These are the ears, back of the head here. It's kind of flat. What is the one thing you probably don't want to miss? Craniosynostosis, right? Very common, but busy pediatricians, you're going to see that. And I see, pediatricians getting plain skull films and CTs to try to sort that out. Well, if you look at them, and this used to be new to pediatricians, and this actually came out of the pediatrics literature, but most people know this now, you can pretty reliably tell quickly by physical exam what's going on. If you look at a kid with deformational plagiocephaly, on the side they're flat, their ear is sheared forward, and usually that forward is a little more prominent. There's an obliquity to the head. It's kind of trapezoidal. In a kid with craniosynostosis, it'll be the opposite. It's almost like an area of negative growth. It'll be the opposite. Or these will be an indeterminate position. You'll see other things, ridging of the suture, bulging in the occipitomastoid region. It's very rare, but there are a lot of kids who have this sort of indeterminate position. Plain skull films usually aren't helpful, even with expert radiographers. So you have to decide what is your threshold that you're going to refer. If you can tell easily, and that's probably 90% of kids, fine. If you're not, then I think you have choices of referring or getting a CT. But I don't see plain skull films as being very helpful, even in our hands or the neuroradiologists that I've worked with. But most of the time, if you just remember this, you're pretty comfortable. So I came to this town from Emory University in Atlanta in 1999, and I personally have seen and treated 9,683 patients with plagiocephaly through 2012. And I'm going to review our experience with this for you, and kind of the things I've learned since I've been here. That's the number. It's a huge number, obviously. It's the biggest one in the literature by far. And one of the things we learned that we kind of knew is most of them have torticollis. So 53% have torticollis. That's actually lower than some reports, but I think it just reinforces if you see a kid with a flat head, look for torticollis. You could make an argument that ours is a selected population, more severe than what you're seeing, and so yours might have less, but still look for it. We helmeted in that group 64%. So for us, helmeting is a social decision. No one has to be helmeted with deformational plagiocephaly. There is no functional aspect to it in my view at all. It's about, you know, your kid gets out of the pool when he's 6 years of age, the hair is wet and you see a little flatness. Will that bug you? And when I came, I set this up and I don't get a dime for it. So I'm completely divorced from it financially in any way. It's done in a non-profit fashion. So I hope we've been balanced over the years in how we present it to our families, but that's the percent that does it. When we do the helmet, for us, it's about 3 months. And that's important too as a pediatrician because helmets have to be FDA approved. But what happened is a mail order company got FDA approved, Starband. So now everyone, wherever you go, you might run into this, can get a scan, send it to Florida, they make a helmet and they send it back. Which to me is an abysmal idea because it's the end user that's important. It's the orthotist wherever you are or the physical therapist. So I've seen kids coming in with helmets for 6, 9, 12 months. So just file it away. If the helmet's done right, it should be about 3 months. And if you see something beyond that, start asking some questions. The other thing that was very interesting, when we set this up, you actually had to be credentialed to prescribe a helmet. Because I thought, well, we're going to be getting, you know, I'm going to be treating all this craniosynostosis. They're going to come in with these plagiocephaly kids. It's going to be hard to sort it out. Actually, not true. Craniosynostosis in this group, and actually that's a large number because of lambdoid kids, because it's 2% of craniosynostosis, so you can imagine that's a pretty large number. Very rare. It's 0.4%. So that might have implications for how we do it in the future. It may actually be that, you know, Fairview University and Fairview Hugo should have the helmet systems in their clinics. Southdale Peds. Maybe not us, is what this has told me in the last year. Torticollis kids, I saw almost 6,000. Of the ones we treated, therapy was about 146 days. Why is this important? Because the biggest problem I see in children who are getting outside therapy, so they're not at a pediatric medical center, you know, they're in Brainerd, is being discharged from therapy before it's cured. Happens all the time. In fact, almost everyone who comes in, that's the first thing I'm looking for. They said, well, we had torticollis, but we cured it in Crosby, Minnesota. You know, the kid's going to have torticollis. So it isn't a quick fix. 95% are cured, which is what we found. 95% of the kids I've seen were cured with therapy alone, but it was not a quick fix. If you look at the literature, one of the largest series I saw before this was a little over 1,000 patients. And they were doing, which is also a 95% cure rate, what we do. So what does therapy mean? Because therapy means a lot of different things. Again, it's very murky, like plastic surgery. At the end of the day, in therapy, what needs to really happen is passive and active range of motion. So if the therapist is just getting down and doing what I call play therapy, they're playing, I'm getting the child to do the things they want to do, turn the way they want to do, tilt the way they don't want to go. That's not enough. That's the easy part, though. Then there has to be passive range of motion where you're passively stretching the child. And that's the first thing that people want to stop. Because these kids are smarter than we are, and they know what you're doing. They fuss it and they cry. But if you do both of those consistently, and consistently for us has always been twice a day or more or greater by the family, you're seeing a therapist on the average of every 2 weeks. You get a 95% cure rate. For us, the percent of sternocleidomastoid release was about 5%. So that's our go-to when the kids weren't cured. You can take this with a grain of salt because this was not in our database, and this, you know, we're publishing and is going to be presented at the International Society of Craniofacial Surgeons this fall. This is not hard data, but I don't recall, and I'm a biased observer, I'm a surgeon, right? But I don't recall a family have done a sternocleidomastoid release on who didn't say it helped. There's still some we haven't cured. For a grand rounds I gave at Children's, informal chart review, it seemed it was about 10%. And then for us, that's the end of the line. I don't have anything else. And we used to send them back to pediatric spine surgeons for second opinions. We don't even do that anymore because no one's come up with anything. So an approach to this, deformational plagiocephaly. We talked about, you diagnose it by physical exam. You don't need x-rays. We talked about how to do that. Physical therapy, if there's torticollis, we use cranial orthoses selectively. They're really not controversial anymore in my view. They work great. You know, we published that paper too about patient satisfaction and perceived results, et cetera. The only controversy I see is we have no idea who to put them on. We have no predictive data about plagiocephaly. Some people pretend they do. They take measurements. They take x-rays, heaven forbid, but we don't. So that's the problem with that. Then if there's failure to regress, then we start getting these images. Most of those kids are referred at that point. We use something called the Cranial Cap, is what we set up when I came here. Do you guys have a helmeting program here on campus? Okay, so it's probably pretty similar to this. I'm not going to bore you with it then. It's an optical scan. We scan the kid with light. It takes 2 weeks to make the helmet. They're seen about every 2 weeks. This is the study I was just talking about. We ran them, when we said, well, how well these work, we actually blindly and randomly surveyed the families and had them rate this change. And this is in Journal of Craniofacial Surgery. And the bottom line is patient satisfaction's off the wall, and that's been seen everywhere. The things work. We just don't know who to give them to. So the things work great. So here's an example. Here's a kid who's pretty flat. Here's after 4 months in a helmet, and nothing else is going to do that. But again, brain's fine. No functional problem. Now to some more gee whiz stuff. So that's stuff you're going to see every day. This is stuff that you see more rarely you're going to refer. Craniosynostosis is probably the big thing that we do. We do 1 or 2 intracranial cases a week. I used to come here to Fairview. I haven't in a long time done cases here, but most of this we're doing at Children's or Gillette, it seems. Not exactly sure why that is, frankly. But Gillette, is our home base, but I'm not sure why we're not doing as many cases over here. But we've done 1 or 2 cases, if you add up everywhere we go, a week, pretty consistently. And the new thing in treating these kids is resorbable fixation, new in the last, say, 10-ish years. So we move the bones of the head and face in children around. And in the 90s, we used to fix them together with little titanium plates and screws. Well, you don't have to be a craniofacial surgeon to figure out if you put a titanium plate on a 6-month-old or a 4-month-old's head, that bone may not grow very well. And then the other thing that happened is as they grew, the plates would migrate intracranially. So this is the inside of the head of a child that we were operating on, not mine. You see these screw points sticking in. The concern was that some child was going to get a head bonk, get a subdural. There was a huge push in the 90s to get resorbable fixation in craniofacial surgery. And one company was able to do it in the late 90s. They had a limited release for, I think, about 2 years to 12 surgeons in North America. I was one of them. So we have a big experience with this I'm going to show you that has revolutionized, for me, craniofacial surgery in these kids. And basically, these are plates and screws. For now, it's rivets that we ultrasonically weld onto the skull that absorb. They're made of the stuff that the absorbable sutures are made of, and they resorb in about 9 to 14 months. They don't integrate intracranially. They don't restrict growth. We've published a large experience with this, and again, the bottom line is the stuff works great. Doesn't get infected, resorbs, everyone's happy. I'm not going to bug you guys with some of the technical aspects of this. In another paper we published looking at the Resorbix is the newest stuff on the market. Again, works great. I think you get that. So here we are putting it on. This is a top of a child's skull. These are the plates, like little mesh plates. We can cut these with scissors. We have a little water bath. We can mold them. And you drill. And then at the end of this, there's a little rivet. You push a button, and there's an ultrasonic probe at the end of it that vibrates and melts the rivet right into the bone, into the interstices of the bone. So it's electrically fast. A standard case for us is less than 2 hours. A sagittal is about 30 minutes. Incredibly fast, which is important in craniofacial surgery because that means less blood loss, less infection. So you press that button, it welds into the interstices of the cancellous bone, very rigid fixation. So craniosynostosis, a lot of you guys know this, is premature fusion, right, of the bones of the skull. Not that rare. I'm alone seeing 1 or 2 a week. And, you know, other people do this. I know Martin Lacey comes here. He's an employee of Gillette as well, and Martin does some, and there's people at Children's do it. So a lot of it around. It's not completely benign stuff. This isn't cosmetic. Even single suture craniosynostosis does have a significant rate of increased intracranial pressure. So it's important not to miss this. And sagittal is the big one for pediatricians, sagittal craniosynostosis, because we want to diagnose this early, and we'll talk about that. The head shapes are stereotyped by their appearance, and again, all these scaphocephalies, trigonocephalies, these cephalies don't talk about a disease. It's just an appearance. So you can have trigonocephaly from a lot of different things. Optimum age of repair, this is important. So this is where pediatricians sometimes get burned in my experience. The sagittals, which are the most common, it's about 50% of craniosynostosis, we want to fix at 4 months. Well, how many kids have the, quote, toaster head of prematurity or deformational changes that are significant still at 3 to 4 months of age? A lot, right? So it's hard. And I don't have good advice except that, you know, if you're a senior person, you go with your gut. Does this look out of range for what I know? If you're not, go to the most senior pediatrician in the clinic and say, is this out of range? You can refer them at that point. I wouldn't get plain skull films. If you don't want to refer them, then get a scan. I don't see plain skull films as being that helpful. If you're referring them, we don't necessarily want a scan. We get a scan now in 10 minutes, literally, without sedation, minimal radiation. You know, I mean, it's probably the same in your clinics here. It's just not a big deal anymore, so we don't need that. But that's the problem. Diagnosing sagittal early. The others you have time to look at. And a lot of stuff sorts out between that 4 and, say, 9-month well baby check, right? So trigonocephaly, I think you get that. You're fused here. Your head can't grow like this, so it grows like that. Here's a kid with metopic synostosis, significant trigonocephaly, hypotelorism. Here she is at surgery. That's a 3D CT scan at surgery. So the incision is up here. You're looking down. There's the orbits, anterior fontanelle, coronal sutures. Here ours now. I've readjusted the bones. That's an absorbable plate there. There's one there, one there. And we make it a wavy incision so that when their hair is wet and they're older, it doesn't part along a straight line scar. We call it the stealth incision. And so here she is post-op. The standards with single suture craniosynostosis are like unilateral clefts, even more so. The vast majority of our craniosynostosis kids go to school, kindergarten, and are undetectable as a conversational distance as ever having had surgery, let alone craniosynostosis. You have craniosynostosis kids in your practice, they look bad, something's wrong. Like clefts, red flags should go up. Coronal craniosynostosis, so you're fused here, you can't grow like this. So you have a swept back forehead. Little harder to show on these two-dimensional images, but you can see how the forehead's back here. Here's the 3D CT, fused here. Here's an open coronal. At surgery, swept back here. Here we're fixing it. See the plates? That's where the anterior fontanelle was. Kid afterward, normal-looking kid. Scaphocephaly. So this is the one, again, in my experience, is the toughest for busy pediatricians. Now, you're not going to miss this, right? So this is a kid truly scaphocephalic, fused suture. Here's after repair. Again, normal-looking kid. You can sort of see the scar back here, peeking out a little bit. Got short hair. Another kid with scaphocephaly. This is actually another hospital administrator's kid. Significant scaphocephaly. I don't think anyone in this room would miss this either. But there are subtler forms. I should put some subtle forms in this talk. Here he is after. Again, I think you get it. There's a scar kind of in there. Normal-looking kid. So again, just making the point that even with single suture craniosynostosis, the literature is that about 10 to 14% might have some problem with ICP if they're not fixed at some point in life. Another little pearl that comes up all the time, every day for me, every day in clinic, is a kid with a ridge here and a premature closed anterior fontanelle at, say, 6 months of age. What do you do with that? We don't do anything. We don't even get x-rays. Yes, they closed their, if you get an x-ray, you'll probably see the metopic sutures closed. If their OFC growth curve is normal, so you're not worried about any microcephaly, they haven't, to you or to the family, developed any trigonocephaly, and we want, before we're going to do an operation, we want something that isn't, subtle, right? I don't think anything needs to be done. I just tell the family, yes, they may have closed their matopic suture. When that closes, it kind of zips that fontanelle closed. But I expect normal OFC growth curve, normal head shape. I see one every day. I'm happy to see them, but that's what we do when you have these kids come in with a closed anterior fontanelle and ridge. Syndromic craniosynostosis, this is even more of a no-brainer. This is a referral. The thing that's, so these are, Aperts, Cruzan, Sothray-Chauson, all this, Pfeiffer's. What's basically the ticket here that's new is distraction, and it's becoming even more refined. These are some of the most severely affected kids, the Aperts kids. Mid-face retrusion, a lot of the syndromal craniosynostosis, their mid-face is retruded as well. Here's that kid after repair. Again, does she look normal? Not to me. And you don't see normalization of Aperts kids basically ever. So what's new? Not that new, maybe the last 15 years. It's new in the way it gets refined and applied. In the 50s, a guy named Elizarov in Russia started making cuts in long bones and stretching the healing callus. That then went into Italy, into orthopedic literature, into the United States in the 70s and 80s and 90s, and is a mainstay in orthopedic reconstruction. And then a guy named Joe McCarthy at NYU in 1993 put it in kids' faces. And it was revolutionary because previous to that, if your face is bad or one side of your face is small, we would try to make osteotomies and put in bone grafts. Well, it would resorb, there would be relapse because of what we call the functional matrix. Everything in the face, the skin, the nerves, the bone, the muscle, would try to reattain that position they're genetically programmed to be in. So this, when you stretch something with distraction, you're stretching the muscles, the nerves, all of that. The standard maneuver is a Lefort 3 osteotomy. This is what defines a craniofacial surgeon. We can do these. And it's where you take the face basically off the skull base and advance it. So we're advancing the orbits, nose, upper jaw, standard maneuver for syndromal kids. Here's a kid with Cruzans. Fix the head, retrusion before and after I did a Lefort 3. So mom dyed the hair. I'm not sure why, but it's the same kid. But it has profound effects. You see, he's trach dependent. Well, if you move the face forward, you're moving the tongue, or the palate. You're having huge effects, salutary effects in the airway. So a lot of these kids, it's the only way you can decannulate them, too. So here's a kid, unrepaired kids with Aperts. See the complex syndactyly? Here he is after repair. When I came out of training in the 90s, sort of the feeling was no one really rehabilitated Aperts kids. You rarely saw them be productive in society, get good jobs, get married. Not that getting married is being productive in society, but really fully enter society. I think that's changing a little bit with some of these kids. I think this kid is cute. And I think what has changed that is distraction. Because the skulls were kind of doing the same way. Well, we've got resorbic fixation, but we're kind of doing the same thing. So I think we're going to see, and I think we already are seeing in the last 10 years, a change in the way these kids are now integrating into their peer group and into society. Here's a kid with Binder's syndrome, nasal maxillary hyperplasia, upper jaw and nose is back. With standard orthognathic surgery, 10 millimeters is a lot. You've got good oral surgeons here. They'll tell you 10 millimeters is a lot. So distraction, we can do 2 centimeters. And here she is. I've taken the nose, upper jaw off the skull base. This is attached to a splint in her mouth. She turns these screws twice a day, and it slowly brings her face out into space. Bone forms behind it. You take the device off, and she's got a rigid, stable face. It doesn't hurt. She's smiling. Here she is, upper teeth are in front of the lower teeth. Nothing else to do that. So a very powerful technique. This is a cleft kit. That used to be even 5 years ago. That was very controversial, advancing cleft kid's face. Because they got their teeth up there, right? All the dentists are in the back. Their cuspid is up right by the orbit, and we're going to make a cut. But a guy named John Pauli, and I was a naysayer, started doing a lot of this, and we do it all the time now. We do advance the severe kids. This kid I would call severe. Severely affected midfacial retrusion in our non-syndromal cleft kids. Another kid with Pfeiffer's. Before and after facial advancement. Again, another trach-dependent kid. I guess you guys get the idea. It's a big operation still. We distract mandibles as well. Hemifacial microsomia, it's kind of the standard. And it's become very commonplace. Hemifacial microsomia is not that common. So genetically expressed facial microsomia, they're going to have epibulbar dermoids and vertebral anomalies, microtia. This is true genetically expressed facial microsomia. Distraction is great. We use a multidirectional intraoral expander. That's actually the first generation. There's the second generation. So it sits in the mouth. Mom turns the screws, and we can do a vertical distraction or horizontal distraction. Really complex control of the movement that we get. Here's a kid with facial microsomia. So small on this side of the face. And here he is after. He's wearing that thing. Here he is after distraction. What time are we done? 15? Okay. There he is after. Here he is after. Chin is midline. No scars on the face. Everyone's happy. I think it's a great thing for genetically expressed facial microsomia. Here's the problem. They're not that common. What's much more common is deformational microsomia. So Pierrot band sequence. Fetal constraint, chin's back, they get a big wide cleft palate, tongue is forced into the palate, and they have a small lower jaw. That's pretty common. And people want to distract that because it's common. People want to do distraction. As a pediatrician, red flags should go up. One thing we know is 75% of these kids, and we're talking about the Pierrot band sequence sort of kids, deformational issues, express normal growth if you leave them alone. They grow out of it. And so, senior pediatricians and senior surgeons talk about tightening these kids along, even kids who are pretty fragile, and how they get better. And how in the 80s they never had to operate on these kids. And they went, well, they were probably right. And we do know that if you distract a kid's mandible, you're probably affecting their growth. So I think it's a great thing, and then it becomes very controversial after that. So when are we going to use it? Well, if you apply that amount of thought, you're probably doing the right thing. It does take judgment. If the kid is, you think, going to be trach dependent, an impending trach, you can think an obviated trach. There is a mortality rate, as you know, for yearly for a trach. Fine. But it requires thought, and red flags should go up. Everyone needs to take a step back and consider, and you don't see that sometimes. In the last couple minutes here, just some gee whiz things again. Endoscopic surgery. When I trained as a general surgeon, endoscopic surgery was just coming into general surgery. Taking out a gallbladder in a cholecystectomy endoscopically was not a good operation, but by God, if you're going to go out and practice and go to Southdale and do it, you had to know how to do that operation because women were not going to have that scar on their abdomen anymore. Now it caught up. The learning curve caught up, and actually the complication rate is lower than old open techniques. But there was this huge drive in the late 90s and early part of the 2000s to do endoscopic procedures in pretty much everything. Orthopedics, plastics. So those people then came into plastic surgery training programs, and we looked at ways we could devise endoscopic plastic surgery. Emory, where I used to be, was the hotbed of that. I take very little credit for it. I was just looking at the kids, the pediatric part. And just to cut to the chase, what really stuck was the endoscopic resection of masses. We were fixing facial fractures, we were doing craniofacial surgery. What stuck was endoscopic resection of facial masses. And so, kid with a mass here, even by MRI, we didn't know what it was. There was concern. I'm loath to put a scar here or a big coronal scar. We took it out endoscopically. There it is. Well-concealed scar. Everyone's happy. Dermoids. We do this every day. This is a mainstay in our practice. We published this now a long time ago. Dermoid here. You can talk about, I'm going to hide a scar on the eyelid above the eyebrow, but as soon as you say no scar on the face, when I was doing this and I'd say, I've done 3 of these, I've done 1 of these. This was like the second one I'd done. It was an attorney's kid. No one ever said don't do it. As soon as you say no scar on the face, everyone said go for it, doc. Again, now it's kind of mainstay in our practice. But there's an orbital dermoid. There's a 4mm scope being introduced back in the hair. That's what it looks like removed. Takes about 20, 30 minutes. There, what it looks like endoscopically. No scar on the face, everyone's happy. Hemangiomas, vascular malformations. Again, extraordinarily common. 10% of live births. You're going to deal with it all the time as a pediatrician, or even if you're a radiologist for that matter. The biggest thing is to know the difference between a hemangioma and a vascular malformation. Everyone in this room probably does. So I'm not going to bore you with that, with those slides, but know that or you're not going to sound smart. Also, don't call things strawberry hemangiomas, things like that, port wine stains. A vascular malformation is a vascular malformation. It could be a lymphatic malformation, it's not a cystic hygroma, venous malformation, etc. The vascular malformations you're born with, they never go away, they never change. They can seem to grow, but it's because what you've got is growing. I think all those should be referred, all of them. Even small port wine stains. Doesn't mean we're going to operate on them, we're going to do anything, but I think they all should get good information about what the natural history of these are. Hemangiomas. You're not going to refer all these. They're just incredibly common. You diagnose by appearance. 99% of the time you know what they are. Sometimes it's a little hard to tell, and it's by following them, their growth pattern you know. What is the change in the last 10 years? It's simply this. There is much more aggressive pharmacologic treatment of hemangiomas of the face. If you're in practice seeing children and you have a 2-month-old come in with a hemangioma right here, it's 3 millimeters, it wasn't there 2 weeks ago. What are you going to do with that? You watch it? A lot of people now would refer that, believe it or not. Because the concern is, a month later, it's going to involve the vermilion-cutaneous junction of the lip, and even when that goes away, that disruption doesn't go away. So I see a tremendous amount of these referred now. We don't operate on them, and these, if you don't refer, you're going to get sued, right? Airway obstruction, Cossack merit. I'm not going to bore you with that. But this is what you used to see. Hold on, Julie, it's going to go away. Well, it doesn't completely go away sometimes, and if it does, it does bad things. And this is after I've operated on her, but that lip doesn't look normal. Can't fix it. Corticosteroids, it's all historic, I think. Laser therapy is great for ulcerations, not for much else, I think, or very flat lesions maybe. Here's an ulceration. And the healing is, with laser therapy, by the way, 95% at 3 weeks with one treatment. So if you have an ulcer, it's a good thing. It's kind of what it looks like after one treatment. Alpha interferon is historical, unless they have Cossack merit. Propranolol is the ticket. So all of our kids that we treat now get propranolol. Pediatrics in the December issue has an article that you should all read that are the new guidelines for it. Under 8 weeks of age, basically you have to admit them to initiate, which is new. Was not the way we were doing it, most people were doing it. Under 8 weeks total gestational age, you have to admit. And then you can do it as an outpatient with a couple hours of observation if they're older than that or they don't have concomitant problems. But propranolol is the ticket. I never saw in my time pediatricians want to take responsibility for high-dose steroids. A lot of pediatricians are running the propranolol show. I'm fine with it. We're happy to support pediatricians. If you want us to just look at it or talk to us, whatever. You want to run the show, I'm fine with that. I have no problem with it. But I never saw that with steroids. It's kind of interesting. But that's the thing. It does wonderful things. So here's a kid 5 months old age, of age with a hemangioma. Got some therapy, got a little better. 2 months later, better still. That change would have been a big change on steroids. Here's a kid with nasal hemangiomas. These used to be a disaster. And an orbit here. This is on propranolol. Basically, it's gone. Just went away. Gone. So you get the picture. Great stuff. I never saw, in the 3 years we've been using it, I haven't seen a problem. We had one, I should take that out. We had one problem. We had a mom who was also nursing, she didn't tell us, with an antihypertensive. I can't remember. So something was coming through the breast milk, and the kid did get a little hypotensive. Other than that, I haven't seen a problem. Practicing pediatricians have told me they've seen night terrors, but it's just been great stuff. Final thing in the last 30 seconds is nevi. I've got a whole bunch of slides of nevi. Here's the thing. You see a giant nevi, you're going to refer. Significant risk of malignancy, 10 to 14% when you look at it. It's aggressive melanoma. It's uniformly fatal. We do multiple heroic operations trying to reduce those. What about 4-month well baby check? There's a 4 millimeter nevus there. Did I say giant hemangioma? I meant giant nevi. 4 millimeter nevus here. What do you do with that? Well, there are several retrospective studies that suggest that even those are at increased risk for malignancy. And most of my dermatologic consults, including some of them we work with here, I can't tell you all of them, but I know we've gotten a lot of kids from Peter Lee and think that there's something to it. So most of the small ones now are getting referred. And the highest rate I've ever seen in the literature is 2%. Well, 2% of those kids are not getting melanoma. We'd have melanoma all over. So I don't know what the rate is, but it's got to be very low. My approach is I tell families that, hey, it's controversial. There is some suggestion that increased risk. We don't know what it is. It must be so low that it's difficult to detect. Here's what it takes to get rid of it. If it's a scar here, we almost always remove them. If it's a portion of an eyelid, deforming, potentially vision-threatening, more judgment needs to be applied. So it's a judgment call. That's all I had, and we've got 10 seconds left, so if there are any questions, I'm happy to try to answer them. Thanks again. It's good to be back.